market. And I just want you to know that this is a recording, so you might see a notice on the screen saying that you are being recorded. We are going to start today with a couple quick little videos. We're going to go through the videos real quick, and then we'll discuss what the videos showed. So what I want you to see here with this video is watch how they are supporting that perineum as the head comes out. Now they're checking for a nuchal cord, very important. If you can reduce that nuchal cord, we want that done. Otherwise, if it's too tight, it will have to be cut and clamped. Just remember, if that happens to be the case, if you're there and the physician's not there, just remember that you have to, if you cut that and clamp it, that you're cutting the supply from the baby. So gentle traction as the baby's head comes out to help that shoulder. We're going to immediately place the baby up on the tummy, clamp that cord, and you are going to cut between the two clamps. Dry and stimulate the baby. Now with this, they are not using a towel. In real life, you would be using a towel to dry and stimulate that baby. Okay, we're just going to go to the next video real quick.
To perform external uterine massage, first the lower hand is placed in a cupped position over the lower uterine segment just above the pubic symphysis. The upper hand is then placed at the uterine fundus, thereby positioning the uterus between the examiner's hands. The uterine fundus is then massaged gently in a rotating fashion with the upper hand, while the lower uterine segment of the uterus is supported by the lower hand. Upon massage, the uterine muscle is expected to contract and will start to feel very firm. After uterine massage, once again examine the perineum for bleeding and clots that may have been expelled.
All right, so just give me a second here while I toggle between screens. Just take a second. All right, here we go. So what I wanted to show you in those videos is if you have a patient who is coming to your ED for an immediate delivery, which is probably what you're going to see. You're going to see someone who's coming in ready to deliver. You need to be able to know when or what to do with a precip delivery. Okay. So key points to remember when a patient is arriving in the emergency room. If you have a warmer, make sure that you turn that warmer on as soon as you know that you're not going to be able to transfer them out, or if you're at Citizens, they're coming in and you don't have enough time to transfer them somewhere else. Make sure that you have suction and oxygen and allow that warmer to pre-warm even if the patient is not complaining of labor. Make sure that you have your precipitous delivery tray and have it available even if the patient seems to be remote from delivery. And then if your patient is going to deliver very soon, notify your transport team. If you're at a facility that has labor and delivery, obviously we want to get that patient to labor and delivery if we can. But you know, sometimes when these babies want to come, they want to come and you're not going to have time to do it. So that's why we're kind of going over this, just to make sure you know what to do in those cases. So when the baby is born, make sure that you have warm blankets. This is very important. Warm blankets on that baby. Dry the baby off. That's stimulating the baby, will help it cry. And then as soon as you dry that, you want to get rid of that wet blanket. Make sure you're using warm blankets. So wipe it off, get rid of the wet blanket, put another warm blanket on, put that baby skin to skin with mama. It's going to be really important to keep the baby skin to skin, because it helps with thermal regulation. And then make sure in your precipitous pack that you have different size masks just in case you have a premature baby that comes in for delivery. So once the baby is born, you've cut the cord, you have the baby skin to skin with mom, the physician at this point, hopefully, is here. You're going to need to be delivering the placenta. So I didn't show you the video of delivering the placenta, but the one thing we want to reinforce with that is that we do not pull on the cord, and it can take up to 50 minutes before that placenta is delivered. As soon as the placenta is delivered, you're going to start oxytocin, Pitocin. So you want to make sure you have that ready to start infusing as soon as the placenta is out. This is going to help with your blood flow, okay? That oxytocin contracts that uterus, makes it nice and firm, and that will help control blood. So if you're unable to give a IV, make sure that you can give Pitocin IM. You can give 10 millunits IM. Before the placenta is delivered, make sure, if you can, the physician should be collecting cord blood and sending that down to the lab. And then you should be doing fundal massage. So that quick little video we showed about fundal massage is really important. If our uterus is boggy, that's what's causing bleeding, okay? So we really make sure that we give that fundus a good little massage. So when we're doing that massage, as you saw in the video, hand over where the pubic bone is. So you're going to help support that lower segment of the uterus. Find the umbilicus and then go from the umbilicus down until you feel the top of the fundus. Once you feel the top of that fundus, just start rotating in a circular fashion and just keep rubbing it until it feels like a softball. It should be nice and firm. You should be checking the fundus every 15 minutes for the first hour and every 30 minutes for the hour after that. I'm going to go back into that here in just a second. So skin to skin for normal delivery. Skin to skin is super important for the baby's thermoregulation. It helps the baby transition easier. It decreases respiratory effort in the baby, keeps the baby nice and warm. Thermoregulation causes stress in the baby because it's expelling too much energy, and then you'll have a baby that crashes on you, and we don't want that. So make sure that you have a hat on the baby's head. Put the baby skin to skin with mom. If mom isn't able to keep the baby skin to skin, if the father is there or another family member, let them go skin to skin with them. It's okay. The most important thing is that we're keeping the baby warm. When you put them skin to skin, put some blankets over the top of them. We want to make sure mom and baby are both warm. And then if you have a baby that you haven't been able to transport, or again, you may be at Citizens who doesn't have a labor and delivery unit, the baby might start wanting to breastfeed within the first hour. Perfectly normal. Signs of that is baby will start licking its tongue, rooting around. It's very, very natural. Mom and baby, if you don't know how to help with breastfeeding, most mom and babies can figure it out until you can get the baby transferred out. Okay, so post-delivery assessment. So as I said, fundus should be firm. You start at the umbilicus. You're going to massage down in a circular fashion. You're going to massage until the fundus is firm, not boggy. You're going to monitor the tone of the fundus and vital signs every 15 minutes during the first hour, every 30 minutes during the next hour, and then hourly until the patient is ready for transfer. So you're going to chart the fundal height. So charting the fundal height, that umbilicus is your 0 station. So if the fundus is -1 finger, -2 fingers below the umbilicus, that's what you're going to chart. You're going to say -1, -2. If it's above the fundus, then it's +1, +2. I mean, umbilicus is +1, +2. If the uterus is off to the side, either right or to the left, it's usually because the patient has to pee. They have to void. So that's important that you keep that bladder empty, because if the bladder fills up, it's going to cause more bleeding because that uterus isn't able to contract and stay small, because that's what's going to control your bleeding. If you do your fundal massage and the fundus remains boggy and it's not firming up, you need to call your physician. This is where your postpartum hemorrhage is going to come in, okay? So a boggy uterus may indicate uterine atony or retained placental fragments. So it refers to being inadequately contracted and having a spongy rather than a firm feeling. This is descriptive of the post-delivery status of the uterus. So you'll see on the pad, you're going to need to be charting. If you don't transfer this patient out, you're going to need to be charting what their blood flow is. So make sure that if they have this heavy, they've saturated this pad in an hour, that's a little more bleeding than we want to see. All right, we're going to go into postpartum hemorrhage. So why is this important to our emergency departments? According to the CDC, approximately 2 out of every 3 pregnancy-related deaths occur outside the day of delivery or the week of postpartum. So approximately 2 out of 3 deaths were determined to be preventable. Deaths can happen up to a year after delivery. So what I really want you to focus on is that 33%. 1 week to 1 year after delivery, 33% of women have a death. So what can you do to help reduce this risk? So every patient that comes in who is of childbearing years, they need to be asked the question if they have had a baby in the last 6 weeks. This can be miscarriage, this can be stillborn. It doesn't have to be a term baby. It could be, you know, a miscarriage at 20 weeks. Know the signs and symptoms of obstetrical postpartum complications. And then you're going to utilize this AWHONS post-birth warning sign tool. Now, Christina has put these in all of the EDs, or she's in the process of putting them in all the EDs. So every patient that you have that comes in who has had a baby in the last 6 weeks should have one of these post-birth warning signs. So they're going to call 911 if they have pain in the chest, obstructed breathing or shortness of breath, any seizures, thoughts of hurting themselves or the baby, bleeding, soaking through 1 pad per hour, or blood clots the size of an egg or bigger. This is probably going to be due to retained placental fragments. Any incision that is not healing, red or swollen leg that is painful or warm to the touch, temperature of 100.4 or higher, or a headache that does not get better even after taking medicine, or a bad headache with vision changes. We're going to talk about more of this later. So next steps. If any of those symptoms are present, it's important to treat promptly. So this may include a consult to the OB if patient is currently pregnant or ended a pregnancy in any way at any gestation in the last 6 weeks. Now there's lots of resources. I'm always available to help you, Christina as well. And then the California Maternal Quality Care Collaborative has safety bundles for cardiovascular disease in pregnancy, preeclampsia, hemorrhage, DVT, and sepsis. All right. Hemorrhage is a leading cause of maternal deaths. So 35% of global maternal deaths. That's a lot. It's estimated 132,000 maternal deaths a year. 14 million women in developing countries experience postpartum hemorrhage. That's 26 women every minute. That's a lot of women. So prevention of adverse outcome depends on recognition of key risk factors, timely initiation of clinical management, active management, and then timely early identification of abnormal bleeding. So risk factors for retained placenta. So if they have a history of placental previa, this is where the placenta embeds to the uterus at low and either covers the cervix completely or partially. If they've had a prior C-section, any post-pregnancy curettage, they went in and scraped the uterus for any reason, manual removal of placenta, they've had retained tissue, uterine infection, and advanced maternal age or high parity, which is the number of children that they've had. So advanced maternal age, we see a lot more women over the age of 35 having babies. So that should be a reminder in your mind. So other factors can be macrosomia, polyhydramnios, too much amniotic fluid, multiple gestation, prolonged or rapid labor, platelets less than 100,000, magnesium sulfate, choreo, infection in the amniotic fluid, or trauma. So how much is too much when we're talking about hemorrhage for a postpartum woman? So 500 milliliters for a vaginal delivery and 700 milliliters for a C-section is average. So most women tolerate that very well. Now, if they have 1,000 milliliters for either a vaginal delivery, which is what you guys would be dealing with, or a C-section, is considered a postpartum hemorrhage, okay? So 4 to 5% of women have greater than 1,000 milliliters. That's a significant amount. So what you guys can do, you're going to identify, see the blood loss, or recognize the signs and symptoms, and I know you see this often. Tachycardia, hypotension, lightheadedness, decreased level of consciousness. You're going to call for help right away. So we really want to make sure we get that OB provider there, right? You're going to have your ED physician, but make sure we get that OB provider in. Anesthesia, get your extra nurses in. You're going to grab that hemorrhage kit, and you're going to make sure that you designate someone to record everything. So resuscitate and investigate. You're going to manually massage that fundus. This is so important. I cannot stress it enough. Massaging that fundus is going to be your first line of defense, okay? Someone needs to be massaging the fundus while someone else is starting another IV, just in case you need to give blood, giving your meds, whatever. It's very important to have your hands on that fundus and you're rubbing. You're going to give meds, examine the vagina. Do they have a hematoma? Do they have any tears? Are there any lacerations there? Is there a slow leak? Make sure you get that second IV in just in case you have to give blood. Put your Foley catheter in. Remember what I said earlier, if the bladder is too full, the uterus cannot contract to control the bleeding. So we want to make sure we're keeping that bladder empty. You might need to give crystalloid fluid bolus. You probably will. Vital signs are going to be every 2 minutes. Your systolic blood pressure should be greater than 90 or a MAP greater than 65. Make sure you have a type and screen or type and cross, CBC, coag profile. Keep the patient warm, give oxygen, put them in Trendelenburg, and consider transfer to OR if you cannot stop the bleeding. So why are we bleeding? Uterine atony, is that uterus boggy? Do we have lacerations, vaginal or cervical? Is there retained placenta? This is probably 70%, I would say, is probably retained placenta. Uterine inversion, did the uterus come into the vagina? And this can happen with multiple pregnancies. If that uterus is, they have 3, 4, 5, 6 kids, that is probably more likely to happen. Coagulopathy, resuscitate. So consider activating your massive transfusion protocol. You're going to have packed red blood cells, fresh frozen plasma, platelets, and cryo if your fibrinogen is low. Having trouble getting the words out this morning. All right, so your medications. Very first thing you're going to do is give oxytocin, Pitocin. Either 30 units in a 500 milliliter fluid or 10 units IM. Then you can give Methergin, but you need to make sure that the patient doesn't have any hypertension because that's going to be your contraindication for Methergin. Hemabate is also one that we give, and it should be in your, these should all be in your kit, but don't give Hemabate if they have asthma. And then you have Cytotec, which we usually give either rectally or sublingually. All right, very, very important to get that second line in before vasoconstriction develops. If they're having a significant postpartum hemorrhage, this is extremely important to get that second line in. So how much is too much? Accurately quantifying blood loss is difficult, especially if you don't have a scale. Labor and delivery have a scale. They're going to weigh everything that has blood on it. But you guys probably aren't going to have that ability to do. So you're going to need to look at it visually. So many severely anemic women cannot tolerate even 500 milliliters of blood loss. This is important because a lot of pregnant women are anemic. Clinicians usually underestimate by half. It's a lot. And then that slow, steady trickle, I mentioned that earlier. Slow, steady trickle cannot be ignored. That slow, steady trickle adds up. So we've given you some slides here to look at to kind of, and this will be in your education binder on your unit. So you're going to have a Yale OB blood loss estimator. That's what this is. Look at the difference between the peri pads, between 100 mLs and 300 mLs. You see that 300 mLs, that should be a warning sign to you that she's bleeding too much. You get a couple of those and you're going to be in over 1,000 right away, right? And that doesn't include what she had at delivery, if they delivered in the OR. Your full kidney basin and your chucks. So look at this quilted bed pad. That's 250 milliliters. When you're looking at it, yeah, it's a bit, but you don't really, you know, it's not really exciting, right? But if you change that frequently and you're having that, so you're changing that every, 15 minutes or so, that's too much bleeding. So here's the chucks pad with the same 250, and then we'll look at the mannequin over here. That's 1,000 mLs. Okay, that's a postpartum hemorrhage. So our CMQCC transfusion guidelines for massive ongoing hemorrhage. Resuscitation transfusion is not based on labs, but your clinical presentation. It seeks to avoid coagulopathy, transfuse with uncrossed PRBCs until crossed blood available, goal near equal ratio of packed red blood cells to FFP after the first 2 units. One unit of platelets given for every 4 to 6 units of packed red blood cells. So the lethal coagulopathy triad, dilution, hypothermia, and acidosis. This is what we want to avoid. Dilution, a transfusion of crystalloid and packed cells devoid of clotting factors. This can be a problem once 1 to 1.5 total blood volume is replaced. So we're giving lots of fluid, but we're not giving blood. So we need to make sure that if we're giving lots of fluid and this hemorrhage is continuing, we need to get that blood started right away. Hypothermia significantly decreases platelet function, even if counts are adequate. Keep your patient warm. Grab that bear hugger. Put the fluid warmer on. Acidemia occurs with massive hemorrhage due to hypovolemia, peripheral tissue hypoxia. So as those hydrogen ion concentration increases, enzyme functions involved in coagulation pathways stop functioning. This is very difficult to reverse. So we want to work to prevent that metabolic acidosis. So Melissa Price had a late postpartum hemorrhage. Melissa recalls asking the nurses how they could tell how much blood she was losing. The nurses never weighed the blood, and they dumped it from a bedpan into a portable toilet. So this should be a big warning sign. If you're using a bedpan and that bedpan is full of blood, you better be initiating your postpartum hemorrhage protocol. That should be a huge warning sign for you. Melissa tells of feeling sheer panic when the bleeding started up again. Enormous clots. I screamed, and I will never forget the look on the nurse's face when she lifted up that blanket. I just kept thinking, God, give them more time. They need more time to save me. Melissa ended up with a hysterectomy and about 12 units of blood transfused. All right, so again, very, very important to keep an eye on how much blood that patient is having. This is going to happen with you if you have any kind of pre-sip delivery at the ED department, or if a person comes in postpartum and she's bleeding. It's probably going to be due to retained products of conception in the placenta, retained placenta. Or if they've had a miscarriage, then that was what you would be seeing them for. All right, hypertension and pregnancy. Now this is a new focus, so this is super important. Chronic hypertension, gestational hypertension, preeclampsia leads to eclampsia, which is categorized by seizures, preeclampsia superimposed on chronic hypertension. So risk factors. Their very first birth, very first pregnancy, first birth, history of preeclampsia, African American race, 30% higher incidence of preeclampsia or hypertension in African Americans. Smoking, diabetes, chronic hypertension, obesity, low socioeconomic status, maybe they're not getting the care that they need, and advanced maternal age. So what I want you to look at on this slide is the postpartum portion. I think you guys probably deal with patients who present who are pregnant. You guys are really good about calling the physician, the OB physician, or sending them up to labor and delivery. So what I really want to focus on is postpartum here. So late postpartum eclampsia occurs more than 48 hours, but less than 4 weeks after delivery. We're telling you 6 weeks. So greater than 48 hours is 5 to 26%. It's a lot. Proteinuria, so preeclampsia, if they have a 24-hour protein greater than 300, and severe eclampsia greater than 5 grams in 24 hours. Symptoms of preeclampsia with severe features. This is really, really important because you guys see blood pressures much higher than this all the time. But in a pregnant woman or a woman who is up to 6 weeks postpartum, this is severe hypertension. So if you have a systolic blood pressure greater than 160 or a diastolic greater than 100, it does not have to be both. It can be one or the other. If they have right upper quadrant pain, thrombocytopenia, renal insufficiency, impaired liver function. So your liver function panel is going to be elevated to twice the normal. Pulmonary edema, cerebral or visual changes, your headaches, your blurry vision. So worsening hypertension. So if you have a patient who is pregnant, who has come in 6 weeks after delivery, if their blood pressure is greater than 160 or their diastolic is greater than 110, you're going to do another reading in 15 minutes. If you get 2 high readings within 60 minutes, they do not have to be consecutive. That is severe hypertension and you need to treat it. So blood pressure levels should be kept controlled, we want them less than 160 or 110. You're gonna, all of the ADs will either have a virtual kit or a real kit. We're in the process of working on this for you. You're going to use labetalol. So labetalol, you're going to give 20 milligrams IV for the first dose. You're going to repeat blood pressure in 10 minutes. Or you can do hydralazine. If you don't have an IV, give them nifedipine PO. And then diuretics are indicated in the presence of pulmonary edema. Now, this last bullet here, though magnesium sulfate can lower blood pressure, that is not its purpose. So the purpose is for seizure prophylaxis. So if you get an order to start magnesium sulfate, that's awesome. But you need to remember that you have got to be giving something else in addition to that magnesium to lower the blood pressure. So while you've got that magnesium bolus going, we need to be giving labetalol or hydralazine. Diagnostic criteria for severe preeclampsia: cerebral visual disturbances, persistent headache, hyperreflexia, clonus, altered level of consciousness, if they're seeing spots or blurry vision or blindness. Pulmonary edema or cyanosis, so low O2 sats, RELs, tachycardia, increased CVP, shortness of breath, or distended neck veins. HELLP syndrome, hemolysis, elevated liver enzymes to twice normal, and a low platelet count. All right, the only cure is delivery. Again, that's if they're pregnant, but we're focusing on postpartum preeclampsia. So resolution after delivery is not immediate, and many women may initially deteriorate after delivery. Some may even represent to the ED with worsening disease. For most women, hypertension will resolve within the first week postpartum, but if they don't, So hypertension that persists more than 6 weeks postpartum usually represents a pathology not directly associated with pregnancy, such as essential hypertension or underlying disease. Proteinuria present beyond 6 to 12 weeks postpartum may also be an indication of an underlying issue. All right, each unit is also going to have this tool, your preeclampsia early recognition tool. These will be in resource books for you guys. What you need to focus on is this severe level. So red, again, that systolic blood pressure over 160 or diastolic over 110. This says 105, but what we've been teaching is 110. And this is going to give you a little algorithm of what you should be looking at and how to treat it. All right, so documentation. If you have that patient who comes in and has a precipitous delivery in your ED before you can transport them out, every baby needs to have an APGAR score. You're not going to be able to remember this, but it usually is the nurse's responsibility to give an APGAR score. So this is also going to be in your binder. What you need to be looking for is activity. Do they have a heart rate below or above 100? Are they grimacing? Are they crying? What does the skin color look like? And their respiration, is it regular? Are they vigorously crying? Are they grunting? These kinds of things. You'll have this as a tool to help you look at it. We're going to do APGAR at 1 minute and at 5 minutes. If we want that score to be above 6, if it's not, if at your 5 minute it is not above 6, we're going to do another APGAR score every 5 minutes until it's above 6. So in your precip kits, you should have your infant identification banding. So make sure before that baby leaves that room with the mother that you have banded the baby and the mom. You're going to have your newborn admission record, and you should have a baggie with cord blood labels, your infant labels, and bands. So again, if you have a baby in the ED and you haven't been able to transfer it out, vital signs have to be done every 30 minutes for the first 2 hours of life. So you're going to check the heart rate and respiratory rate by listening with the stethoscope. The days of doing cord pulsation for a heartbeat are no longer here. This would, you would really use that in, if your baby isn't vigorous, if you've got a baby who you might have to be doing some resuscitation on. But for a normal baby, regardless, you're going to be checking the heart rate and respiratory rate by listening with your stethoscope. And you're going to count for 1 full minute. Make sure you're checking that temperature. We got to make sure that that baby is nice and warm, and the temperature needs to be above 97.5 axillary. If it's not, put the infant skin to skin to warm the baby. If that's not helping, we need to get a warmer and get that baby under a warmer. If your baby is grunting, this is a sign of respiratory distress. So we call grunting or singing, where they kind of hold their breath and they're like, that's grunting. It's respiratory distress. They're trying to open up those alveoli. So we're going to place a pulse ox on the infant's right hand or wrist. So you can put it here on the hand, or you can put it here on the wrist, and you'll give oxygen as needed. This is going to be a baby you're going to be watching. Infant can take up to 10 minutes to completely pink up. Now I'm also going to put this in your OB resource pack. I really want you to look at this because it can take up to 10 minutes for a baby to really get nice and pink and have an oxygen saturation above 85. So if at 10 minutes you put that pulse ox on the baby and their oxygen saturation is 87, that's normal for a baby, okay? So we're not going to do any, if you could do some blow by if you feel that that is necessary, but it's really not. I would just continue watching it, make sure it continues to go up. If you have a baby greater than 20 weeks, you're going to do your standard pre-transport. Just make sure you're filling out your admission assessment. You guys have all your documentation that you're using for transport. When you do send the baby out to your receiving facility, it's really important if you can give them in report what their G's and P's are. So that means how many times have they been pregnant, how many deliveries have they had, and what the gestational age of the baby is. All right, so cardiac arrest in pregnancy. Cardiac arrest occurs rarely, but modifications for resuscitation for pregnant women are required. And then if you do have a patient come in and cardiac arrest and CPR has been initiated, we have 5 minutes to get to deliver that baby if ROSC is not achieved. We're going to go over that a little more here. So causes of cardiac arrest in pregnancy: pre-existing medical conditions, obstetric complications, random catastrophic events. Leading cause is hemorrhage. So points to consider when we're doing CPR: you're going to compress the sternum, but it's going to be slightly above center. And if you have to do any kind of airway obstruction, chest thrusts are replacing abdominal thrusts. So compressions on a pregnant patient. I'm going to show you a slide, positioning here in the next slide. But the days of tilting the uterus, putting a wedge underneath the patient, or moving the bed up, those are gone. We're going to keep the patient nice and flat. You're going to perform your CPR, and someone else who is not doing compressions, obviously you're not doing airways, someone else is going to be manually doing uterine displacement. If you are continuing with CPR and ROSC is not achieved within the first 4 minutes, you will be doing an emergent C-section. Time is the most crucial factor when performing CPR in late pregnancy. So here's a picture of that left uterine displacement. We're no longer tilting the bed. Look at the picture with the smiley face. You can see you can either use one hand to do the uterine displacement, or you can use 2 hands. Main thing, we really want to get that uterus off the main artery. So OB consideration: circulation. You're going to follow your ACL guidelines for meds, and you're going to make sure you're doing that left uterine displacement and compressing slightly above the center of the chest. Airway. In pregnancy, women have a lot more swelling, so their esophagus may be more swollen, so you might need to use a smaller ET tube than what you normally would. In late pregnancy, for breathing, use esophageal detector and decrease your ventilatory volumes. You're going to use your standard dose for ACLS for defibrillation. And if no ROSC within 4 minutes, uterus evacuation by 5 minutes. This means an emergent C-section in the ER. This is at only if it is 20 weeks gestation or above. So either the level of the umbilicus, the uterus is at the level of the umbilicus, or you know that the gestation is above 20 weeks. Evacuation of the uterus will occur wherever the patient has arrested. It is inappropriate to transfer patient to the OR suite first, as this inhibits resuscitative efforts. So we're not going to be transferring the baby to the OR. We're going to be doing it in the emergency room to get that baby out. So full CPR should continue during delivery. If you're having to do an emergency C-section, we're going to continue doing those chest compressions and airway management. Make sure that we know that the fetus is above 20 weeks, length of time between arrest and delivery, and fear of litigation is some of the reasons why they don't do it. So research has determined that ROSC was recorded immediately after delivery in this scenario. No cases have been reported of worsening maternal condition immediately after delivery. And the critical point to remember is that both mom and baby may die if the provider cannot restore blood flow to the mother's heart. So for infant outcomes, the outcome of the surviving infant from time of arrest until perimortem of cesarean delivery. So if you can get that baby out within 5 minutes, they have 98% of having an intact neurological status. As the minutes get longer, that percentage continues to go down. So it really, the research has really just shown that it's imperative that if we have a situation like that, that we do a emergency section. That's it, y'all. What kind of questions do you have? Anybody have any questions for me? If you have any questions, just go ahead and put them in the chat. We're good at Princeton. Awesome. Feel free to reach out to me at any time. I'm always happy to answer questions. If you need any, if there's any other education that you need, please let me know, and I will be happy to put something together. All right, y'all, that's it. Have a wonderful Wednesday, and we will be talking to you guys soon. I'm going to go ahead and stop the recording.